Hi, this is Amber Knowlton. This is Unit 3, Clearest, Muddiest points. I broke down all your papers, and what we're going to talk about is coronary artery disease versus peripheral artery disease, AAA rupture versus dissection and AAA surgery, arterial versus venous problems, VTE intervention, and hypertensive drug therapy. So first, let's look at a couple of pictures here that are going to show us the difference between a AAA rupture and a AAA dissection. So these pictures here you're looking at right now, these are AAA dissection. What happens with a AAA is this section of the artery wall gets weakened, it outpouches, and what happens is eventually, if it gets too big, it will burst. So with a dissection, what happens is, like it says right here, there's a tear in the inner layer. So within this layer here and this layer here of the artery wall, there's a tear and blood starts to leak in there. So it causes dissection, dissecting that wall. And what happens is this wall here is strong, but when you break it in half, it gets even thinner. So the risk of rupturing gets higher and higher because now all that's protecting all the pressure from this blood in here is this little thin wall where this dissected. So just like this picture, this is normal. This is a AAA dissection. There's some sort of tear in that inner layer, that intima of the artery wall, and now blood starting to leak in there. And again, this section of the wall just gets weaker and weaker. Now, this picture here is AAA rupture. So again, showing us the aorta, all the red here are arterial vessels. This is a normal aorta right here. Over here is a ruptured aorta. So what's happened before this hole even got here is you see how this aorta here is just expanding, getting weaker and weaker. Now, there might have been a dissection here in this section of the wall that again has just made it weaker and weaker. But the worst complication result of AAA dissection or having a AAA is that wall gets so weak right here that it ruptures. And now we have a hole in here, and greater than 90% of these patients are going to die because they're going to bleed to death. So this is the difference between rupture and dissection. Here's another picture that's showing you, this is the aorta, right here is where it's going to bifurcate. And you see how the aorta, this is an arterial vessel, how it's just stretched and stretched and stretched and it's gotten big. Well, eventually that wall just can't take that pressure, so it ruptures. And you see right here, all this blood leaks out. So whether the patient has a dissection or a rupture, surgery is going to be needed. Now, in a rupture, surgery is emergent. We don't have time for pre-op teaching. We don't have time for pre-op testing. These patients, if they make it to the hospital alive, need to directly go to surgery. That's an emergency. Now, if we have a dissection, or if we know the patient has a AAA and it's just getting too large and we need to do repair, now we have more time to do some pre-op teaching. We have time for stabilizing the patient before surgery. So correcting any electrolyte abnormalities, correcting hemoglobins, making sure they're well hydrated. Now with surgery, there's a couple of different ways they can do surgery. One, they can go in and they can make a cut, a midline incision, and they can cut open that aorta. They kind of flap it open like a pork chop. You fly it open, and they'll put a graft or a stent inside there. Then they just cover it back up and sew it back up. Or they can do place a graft where they go up through the femoral artery. So they're going to use, this is endovascular grafting, where they go up through the femoral artery and they place the graft. Now, the complications, whether they had an open repair or a graft placed through the femoral artery, complications are going to be the same. There's still a risk of leakage and endoleak of seepage seepage of blood back into that old aneurysm. There's still a risk of an aneurysm developing above or below the section we just repaired. There's always still a risk for dissection to occur. There's always a risk for bleeding, renal artery occlusion, thrombosis, incisional site hematoma or infection. So really the only difference in the care, whether it was an open repair versus a graft placed through the femoral artery, is it's going to be care of the site. Either you're going to have care of the femoral site or you're going to have care of this midline abdominal incision. But for both patients, it doesn't matter what type of surgery they had to fix their AAA, if the patient was a rupture and they are one of the less than 10% of patients that can make it to surgery and they survive, or if it's someone that's had a dissection and we've taken them to surgery, we've put a graft on it, or if it's a patient who we've been monitoring for months to years and their aneurysm has just gotten too large and we take them to surgery. All of these patients, post-operatively, adequate blood pressure is important to maintain that graft patency. So prolonged low BP can help result in graft thrombosis. Hypertension stresses that surgical site, causes leakage or rupture of that site. So we want to control their blood pressure either with antihypertensives. Also, any patient that has any sort of AAA surgery, post-operatively, we want to monitor their cardiovascular status. Also, we want to monitor them for infection. Now, these patients are going to have either a midline incision or they're going to have a femoral site, plus they're going to have all these invasive lines, whether it be an arterial line, which will probably be in their wrist, CVP line, central venous pressure monitoring, which can be done through a central line, or pulmonary artery catheter. All these sites need to be meticulously taken care of for infection. Same with the GI status. Post-operatively, we want to monitor that GI status. If they did an open abdominal surgery, patients are at even more risk of paralytic ileus because we've given them anesthesia, we've been handling their bowel during surgery, and that anesthesia can kind of, stop, paralyze, slow down the movement of the bowels. So we want to assess those patients, and we're always concerned anytime, remember, that aorta is delivering oxygenated blood to the whole body. So anytime we go in there and we might have to clamp, if the surgeon has to clamp the aorta to do the repair, they're stopping blood flow during that time to the body. So they unclamp it. We want to make sure blood flow is restored. We're getting blood to our gut. We're getting blood to our kidneys. We're getting blood to our reproductive organs. We're getting blood to our peripheral extremities, to our brain. So we always worry about with the GI system that maybe there's ischemia of the bowel. Maybe there's not enough oxygenated blood getting to the bowel. So these patients might have absent bowel sounds, fever, abdominal distension, diarrhea. Also, we want to do a neurovascular assessment of the lower extremities. We should check and record all peripheral pulses hourly. A decreased or absent pulse with a cool, pale, mottled, painful extremity can mean that there's some sort of embolization or that graft has become occluded. So we want to make sure we're reporting this to the physician immediately because these patients might have to go back to surgery. So it doesn't matter if this patient had a abdominal aneurysm that we've been monitoring for years and it just gets larger and larger and we go in and do surgery. Or if the patient has a dissection and we go in and do surgery. Or if the patient has a rupture and they make it to surgery and we do surgery. The post-op care for these patients that had surgery is all going to be the same. Also, immediately post-operatively, we want to make sure we're recording and monitoring their output. We want to notice what their kidney function is because we want to make sure there's perfusion to the kidneys. Remember, during surgery, they might have clamped that aorta, which is going to stop blood flow to the kidneys. Also, decreased renal perfusion can happen from embolization or from a thrombus or plaque, which can cause ischemia to the kidneys. Also, hypotension, dehydration, or blood loss during surgery can also lead to renal perfusion problems. So our diagnostic tests are pretty much going to be the same. Chest x-rays, CTs, possibly MRIs. For a patient that we know has a AAA, we want to monitor that to make sure it doesn't develop a complication such as a dissection or a worser or a more worse complication such as rupture. And also, our drug therapy is going to be the same. We want to control these patients' heart rates. We want to control their blood pressure, whether it be beta blockers, calcium channel blockers, ACE inhibitors to control their blood pressure, and morphine to control their pain. Next is coronary artery disease versus peripheral artery disease. So coronary artery disease, another term for that is atherosclerosis. Coronary artery disease, when we say coronary, we're talking about the heart. So heart artery problems. This is a blood vessel disorder that kind of falls under that general category of atherosclerosis, which is lipids or fat in the arteries. And what happens over time, those lipids build up in the artery and they make that artery smaller and smaller and smaller. And remember, arteries are always delivering oxygenated blood to wherever it's going. So patients' risk factors that put a patient at risk for atherosclerosis is obviously high cholesterol, hypertension, tobacco use, because tobacco is a vasoconstrictor, decreased activity, obesity, diet, and all of that also can relate as well to high cholesterol. Peripheral artery disease is thickening of artery walls, and this can be anywhere in the body, not just talking about the heart. So, and typically when we talk about peripheral artery disease, we're mainly talking more about those lower extremities. So thickening of artery walls, and these patients that are at risk for this are patients with advanced age, diabetics. And again, peripheral artery disease strongly relates to problems with coronary artery disease or cerebral vascular disease. So again, it's important to look at the site of the peripheral artery disease, and that picture is in your PowerPoints where we talked about looking at all the sites moving down the arterial circulation. Remember, we're talking about arterial disease of vessels that are delivering oxygenated blood. So coronary artery disease and peripheral artery disease are closely related because if a patient has a problem with peripheral artery disease, they probably have a problem with coronary artery disease as well. But it's just when we think of coronary artery disease, we focus more on those arteries of the heart and what they can do to damage the heart. And the worst complication we worry about is the patient having an MI, a myocardial infarction. Peripheral artery disease, the difference is we're thinking more and looking more at those thickening of artery walls outside of the heart. So all the other artery walls that we have. And most commonly, we look at the lower arteries in our lower extremities. So a classic symptom of peripheral artery disease is that intermittent claudication, where the patient has ischemic muscle pain. Remember, something's blocking the artery, so we're not getting oxygen down to those legs. So they're going to have this pain, ischemic muscle pain from exercise, usually resolves in 10 minutes, and then they can go back to exercising. The pain happens because there's a buildup of lactic acid. But remember, only about 10% of patients with PAD have claudication. So that means the other 90% of patients might not have these symptoms at all. Patients might have paresthesia from nerve and tissue ischemia. And also gradual reduced blood flow to neurons produces both pressure and deep pain sensation. So these patients might not notice lower extremity injuries. We want to protect them from injury. It's important that you look in your book on page 835, table 38.1, and compare peripheral artery versus venous disease. So remember, anytime we're talking about arterial disease, this is a disease in arteries. Arteries are delivering oxygenated blood. Arteries are what give you a pulse. So if there's any problem with an artery, distal to that problem within the artery, they're not going to get an adequate blood supply. They're not going to get an adequate pulse. The difference, though, is venous has nothing to do with arterial circulation. Venous has nothing to do with producing a pulse. So if there's a problem within a vein, we're still going to get a pulse. Whether it be coronary artery disease or peripheral artery disease, a lot of times these two complications kind of weave in and out of each other. Uncontrolled hypertension, high cholesterol, smoking, poor diet, obesity, lack of physical exercise. These can all complicate and can make CAD or PAD worse. With both, we want to control their cholesterol level. Currently, all patients with PAD should have aggressive lipid management. So improving their diet, being on anti-lipids. Same with coronary artery disease. They need measures that are going to keep those coronary arteries from continuing to constrict. So we have to keep them open. So we don't want more fat building up in those arteries. So again, lifestyle changes and lipid lowering drugs. When it comes to coronary artery disease, the worst complication we worry about is having an MI. And we'll talk about those interventions when we get to the next unit. But with peripheral artery disease, we worry about if there's some sort of occlusion in a peripheral artery that we're not oxygenating all the way to the end of the foot. So we worry about ischemia, we worry about gangrene, we worry about the patient losing that extremity. So for peripheral artery disease, interventionally by a radiologist, they can go in usually through like a femoral artery, and they can put a probe through there, put a balloon in to expand it, and then place a stent. Sometimes that's not always feasible. Sometimes patients have to have bypass grafting. So either they'll take an artery from another spot in the body, or they'll use artificial arteries. And just like that picture we showed in class today on your PowerPoints, they will completely bypass that whole occlusion. So they're going to make a new artery for the patient. So same after surgery, we want to make sure we're checking that operative site every 15 minutes, and then hourly. We're checking for color, temperature, cap refill, presence of peripheral pulses. Remember, this is arterial. They should have a pulse, sensation, movement. Loss of a pulse requires, get a Doppler. If you cannot get a pulse, you need to immediately notify the physician. Again, kind of just following up on artery versus venous. So again, referring to that chart in your book that I just told you about, comparing on page 835, comparing peripheral artery versus venous disease. Remember, the arteries are delivering oxygenated blood away from the heart. All right, this is what gives us a pulse, and our radial pulse, our brachial pulse, our popliteal pulse, our femoral pulse. That's arterial circulation. Venous circulation is returning blood back to the central circulation so that we can pick up oxygen and we can go again. All right, the next topic you guys were unclear about was VTE interventions. So again, this is a venous problem. This is not an arterial problem. So prevention is number one. We want to prevent these venous clots from occurring. So what are those patients that are at high risk for this? We always think of our post-surgical patients. We think of our patients that are immobile, on bed rest, cancer patients, pregnant patients. These patients need to be changing positions frequently, out of bed, ambulating. This is for prevention. Wearing elastic SCDs, TED hose. Also prophylactically, we can give them, for example, enoxaparin, low molecular weight heparin, to prevent a clot from happening. That anticoagulant does not stabilize or dissolve the clot. It prevents new clots from occurring. Also, patients can be on low molecular weight heparin at a higher dose if they have a clot. Patients can also be on vitamin K antagonists such as warfarin, which takes 48 to 72 hours to be effective. We want to make sure we're overlapping that with our low molecular weight heparin until that warfarin is therapeutic. So again, with VTE, we want to focus on preventing this from happening. However, if it does happen, then we need to teach our patients about the medications we're using, all of the education that goes with the meds, with the anticoagulants, diet, lab monitoring, signs and symptoms of bleeding. All right, next is hypertensive drug therapy. The goal of treating hypertension is a blood pressure of less than 140/90, especially our high-risk patients, patients with diabetes, kidney disease, tobacco use. The goal is even lower, 130/80. Drugs for treating hypertension have two actions. They decrease the volume of circulating blood, and they reduce systemic vascular resistance. In your book on page 717, table 33.7 talks about the drug therapy. So again, with all antihypertensive meds, patients are at risk for orthostatic hypotension. They're dizzy. They might fall. So we want them to be changing positions slowly. One class, diuretics, their action in reducing blood pressure is not thoroughly known, but they do promote sodium and water excretion, which reduce volume and reduce vascular response to catecholamines, such as epinephrine. Adrenergic inhibitors decrease sympathetic nervous system, which the sympathetic nervous system brings the blood pressure up. So we want to decrease the sympathetic nervous system. Direct vasodilators decrease blood pressure by relaxing the smooth muscle and reducing systemic vascular resistance. Calcium channel blockers, these cause vasodilation. They prevent the movement of calcium into cells, especially the cardiac cells, which cause excitability. ACE inhibitors, these prevent the conversion of angiotensin 1 to angiotensin 2, and angiotensin 2 is a potent vasoconstrictor. ARBs prevent angiotensin 2 from binding in the blood vessels, which again is potent vasoconstrictors. Some patients do require combination therapy, which is in your book on page 721. So they might have a combination of an ACE inhibitor and a diuretic. Once patients are started on blood pressure meds, they need to make sure they're coming in for follow-up appointments to have their blood pressure rechecked. Side effects of a drug may hopefully decrease over time, but we want to teach our patients never to just stop their blood pressure meds abruptly because they don't like how they're making them feel. And a common side effect of all these drugs is orthostatic hypotension, so have them change positions slowly. Diuretics cause dry mouth, frequent voiding. Taking diuretics earlier in the day might help with this. Diuretics, for example, as furosemide, deplete potassium. And that's important to know because if we have low potassium, the patient's at risk for dysrhythmias.